Uh, my topic is myocardial infarction in a patient posted for non-cardiac surgeries. First, we will briefly see about the definition, pathophysiology and clinical features. So, definition of myocardial infarction is an acute MI should be used when there is an acute myocardial injury with the clinical evidence of acute myocardial ischemia or with the detection of rise or fall in the cardiac troponin values with at least one value above the 99th percentile and with one of the following symptoms like symptoms of myocardial ischemia, new ischemic ECG changes, development of pathological Q waves, imaging evidence of new loss of viable myocardium or new regional wall motion abnormalities, and identification of coronary thrombus by angiography. Myocardial injury after a non-cardiac surgery is defined as the myocardial cell injury during the first 30 days after a non-cardiac surgery due to an ischemic etiology with no evidence of non-ischemic etiology. So this myocardial injury after a non-cardiac surgery includes the symptomatic and non-symptomatic MI, post-operative elevation in the troponin without symptoms, ECG abnormalities or other criteria that meets the universal definition and have no evidence of a non-ischemic etiology for troponin elevation. The majority of cases of myocardial injury after non-cardiac surgery do not present with the ischemic symptoms and are caused by mismatch in the oxygen supply and demand. The risk factors include the comorbidities of the patient, anemia, glucose levels, and intraoperative blood pressure. So the recent guidelines includes the recommendation includes the routine monitoring of cardiac troponin levels during the first 48 hours post-operatively in high-risk patients. Since myocardial infarction after a non-cardiac surgery most often occurs in the first 3 days after surgery without symptoms. Pathophysiology, MI is usually caused by plate disruption, platelet aggregation and vasoconstriction and thrombus formation at the site of atheromatous plaque in a coronary artery. This causes a sudden increase in the myocardial oxygen demand or a decrease in the oxygen supply, which can precipitate MI in patients with already ischemic heart disease. Clinical manifestations of a myocardial ischemia are varied. It starts from angina pectoris with or without the signs of arrhythmias or heart failure to a classical manifestation of myocardial ischemia. So the angina can be graded into class 1, 2, and 3, and 4. Then we move on to the risk stratification of a patient posted for a non-cardiac surgery. So it includes, according to the American College of Cardiology and American Heart Association, Task Force on Perioperative Evaluation of a Cardiac Patients undergoing a non-cardiac surgery, they stratify the clinical risk factors into major, intermediate, and minor risk factors. This guidelines integrates the clinical risk factors, exercise capacity, and surgical procedure to identify the risk of perioperative major adverse cardiac events. First, we will go on to the clinical factors. It can be divided into major, intermediate, and minor risk factors. The major risk factors include acute MI or a recent MI, unstable or a severe angina, and decompensated heart failure. Intermediate factors includes the history of ischemic heart disease, congestive cardiac failure, or stroke or TIAs. Minor factors includes the family history of CAD, uncontrolled systemic hypertension, hypercholesterolemia, or smoking. Then we see about the type of surgery. According to the type of surgery, like high-risk procedures includes the major operations, aortic and major vascular procedures. Intermediate risk procedures are head and neck surgeries, intraperitoneal and intrathoracic surgeries. Low risk procedures includes the endoscopic procedures, superficial procedures, cataract surgeries, etc. And exercise capacity can also be taken into consideration. It can be assessed using Duke Activity Status Index and approximate metabolic equivalence. So if the patient has a less than 4 minutes, they have a poor functional capacity, and if the patient has a more than 4 minutes, it comes under a good functional capacity of the patient. So these are the risk stratification on a perioperative evaluation of a cardiac patient undergoing a non-cardiac surgery. Then we'll move on to the diagnosis. We can diagnose it using a simple ECG. Like with the 12-lead ECG, it can be evaluated for the presence of SC segment elevation or depression, T wave inversion, old MI changes like the presence of Q waves, conduction and rhythm disturbances, etc. So if there is an ischemic changes in the lead 2, 3 and AVF, it says there may be a right coronary artery disease. If there is a changes in the lead 1 and AVL, there may be a disruption in the circumflex artery. Lead V3 to V5 changes present, it may shows the disruption in the left anterior descending artery. We can also look into the exercise ECG or stress test if needed. like to detect the coronary artery disease, as exercise ECG stimulates the sympathetic nervous system. Interpretation of exercise ECG includes duration of the exercise, minimum heart rate achieved, onset of the ST segment depression, degree of ST segment depression, resolution of ST segment depression. Normal exercise ECG indicates there may be an adequate coronary circulation. We can also look into the pharmacological stress testing using dipyridamole thallium. Dipyridamole is an adenosine agonist. It stimulates the effects of exercise, and thallium is a radioisotope. If there is a reversible defect, that is a defect seen on the initial stress image that disappears with rest, indicates the presence of a coronary artery disease. Dobutamine stress echo can be seen. It assesses the regional wall motion abnormality and left ventricular function. Coronary angiography, if needed, as it is an invasive procedure, it is indicated only for an unstable coronary syndromes to rule out the possibility of coronary revascularization. And a simple echo to evaluate the left ventricular and valvular function and measure the ejection fraction. So then we move on to the risk stratification for anesthesia and surgeries. For that, we have to look into the thing like whether it is a modifiable operative risk factors or it is a high risk, the patient is a high risk patient and should they evaluate elective operation should be modified, delayed or cancelled, or if there is a need for coronary revascularization, it can be assessed using Lee's revised cardiac risk index. It has 6 factors. Like the first one is high risk surgical procedures, includes intrathoracic, intraperitoneal or suprainguinal vascular reconstruction procedures. The second one is the history of ischemic heart disease. The third factor is history of congestive cardiac failure. And the fourth factor is history of stroke or TIAs. And the fifth one is the preoperative insulin therapy in a diabetes patient. And serum creatinine more than or equal to 2 milligram per deciliter indicates renal failure. And these are the 6 factors which are taken into consideration in the Lee's revised cardiac index. So the presence of each risk factor contributes 1 point to the index. So the risk of cardiac complications depends on the number of risk factors. Like if there is a 0 risk factor, the event rate must be 0.4%, and there is a 1 risk factor, the event rate is 0.9%, and there is a 2. If there is a 2 risk factors, 6.6%, more than 3, it is 11%. So the nature of surgery can also be taken into consideration. Like if it is an emergency surgery, then we can recommend against delaying the surgery for a preoperative cardiac risk assessment. And if the surgery is an urgent or a semi-urgent surgery, we can recommend the preoperative cardiac risk assessment only if the patient history or physical examination suggests a need for the surgery. Elective non-cardiac surgery, we can recommend the preoperative cardiac assessment if the patient's age is 45 years of age or older, if the patient is under 18 to 44 years of age, we can, with a known significant cardiovascular disease. Cardiac biomarkers can also be looked into, like we can see the NT-proBNP or BNP before a non-cardiac surgery in patients who are 65 years of age or older, or 45 to 64 years with a significant cardiovascular disease, or the revised cardiac risk index of more than or equal to 1. So the recommended higher normal values of NT-proBNP is 300 milligram per liter and BNP is 92 milligram per liter. Then we move on to the management part. So the management includes already taken medication. We have to optimize the already taken medications. Like the patient is on aspirin, we have to withhold 3 days before the surgery. If the patient is on beta blockers, we can continue the beta blockers during the perioperative period. The patient is on angiotensin converting enzymes or angiotensin receptor blockers, we have to stop 24 hours before the non-cardiac surgery, and we can restart the ACE inhibitors and ARBs on day 2 after the surgery if the patient is hemodynamically stable. If the patient is on chronic statin therapy, we can continue the statin therapy throughout the perioperative period. And smoking, the patient should be asked to stop the smoking 4 weeks before surgery, and we can facilitate the smoking cessation. Then we have to then we have to assess the risk of coronary artery disease. So for that, we have to evaluate the acute coronary syndrome. We have to calculate the risk of major adverse cardiac events. If there is a low risk for major adverse cardiac events, we can proceed for the surgery. If there is an elevated major adverse cardiac events, we can look into the functional status of the patient. If there is a poor functional quality like capacity like less than 4 minutes, we can do other non-invasive testing to uh, proceed with the surgery. If the patient's functional capacity is very poor, we can optimize with the revascularization or other coronary interventions, and then we can proceed with the surgery unless it is an emergency. So preoperative CABG or revascularization should be reserved for the patient with a left main disease, left ventricular ejection fraction of less than 20% or severe aortic stenosis. And percutaneous coronary intervention before a non-cardiac surgery should be limited to those patients with the left main disease, unstable angina or MI, and life-threatening arrhythmia due to an active ischemia. So the patients who require urgent non-cardiac surgery but need a prior revascularization should undergo a balloon angioplasty or a bare metal implantation. If the PCI is necessary, then urgency of non-cardiac surgery with the risk of bleeding and events such as stent thrombosis in a patient on dual antiplatelet therapy must be carefully considered. So, if the patient is on a previous undergone previous percutaneous coronary intervention, then for non-cardiac surgery should be delayed after a PCI for 14 days after a balloon angioplasty, in whom aspirin will need to be discontinued perioperatively. And for the 30 days after a bare metal stenting, and for a drug-eluting stent, it should be performed 3 to 6 months after a drug-eluting stent placement. Then we move on to the other therapies like beta blockade therapy. A patient can be given beta blockers to reduce the myocardial oxygen consumption. Like it decreases the heart rate, preload, afterload, or contractility by decreasing the sympathetic tone and myocardial contractility. The drug of choice must be atenolol or metoprolol. If the patient is on another beta blockers, there is no need to change it to cardioselective beta blockers. We should avoid bradycardia and hypotension while following a beta blockade therapy. Alpha-2 adrenergic agonist can be used such as clonidine. It is a centrally acting alpha-2 adrenergic agonist. It is used as a sedative, anxiolytic, and an analgesic. It reduces the hypertension, tachycardia, and norepinephrine release associated with the surgical stress. Statins or lipid-lowering drugs, they can causes a plaque stabilization. They have found to an additional anti-inflammatory and antioxidative properties, and it improves the endothelial function and increases the nitric oxide bioavailability, so it should be continued. The cardiac medications includes it can be taken to decrease the myocardial oxygen demand by decreasing the heart rate, preload, afterload, or contractile state. So like beta blockers, calcium channel blockers, and nitrates should be continued. And drugs that are taken to increase the oxygen supply by causing coronary vasodilation like nitrates should be continued. ACE inhibitors and ARBs can be discontinued on the morning of the surgeries. Clopidogrel should be discontinued for a week prior to surgeries. Moving on to the anesthesia part. So all the anesthetic techniques must aim to keep the myocardial oxygen supply greater than the demand, and therefore to avoid the ischemia. So the essential requirement of general anesthesia for ischemic heart disease are to avoid the tachycardia and extremes of blood pressure, both of which adversely affect the balance between oxygen supply and demand. Pre-medication. A nervous patient may be tachycardic and requires an anxiolytic pre-medications. So can give a pre-medications with like morphine, scopolamine, and benzodiazepines as the anxiety leads to increase in the catecholamine secretion and increases the oxygen demand. Induction. All the intravenous anesthetic agents have a direct depressant action on the myocardium and may also reduces the vascular tone. This causes hypotension, often with a compensatory tachycardia, which may cause myocardial ischemia. Ketamine has a unique property of indirect stimulation of sympathetic nervous system. It leads to both hypertension and tachycardia, so it should be avoided. Intubation. Laryngoscopy is a powerful stressor. It causes a hypertension and tachycardia. This can be avoided with supplemental dose of intravenous induction agent or an opioid just prior to laryngoscopy. Maintenance. Volatile agents have a minimal effects on the cardiac output. Although they do reduce the myocardial contractility, especially halothane, they causes vasodilation. Isoflurane has a property of coronary steal syndrome. It causes pre-stenotic vasodilation, which diverts the blood supply from already ischemic areas of myocardium. So vagal stimulation due to halogen can cause bradycardia and nodal rhythms. Bradycardias can be beneficial by allowing the greater coronary diastolic filling, providing blood pressure is maintained. Analgesia, high doses of opioids reduces stress response to surgery. So non-steroidal anti-inflammatory drugs may have both a useful post-operative analgesic action and an antiplatelet effect, which may reduces the coronary thrombosis. Reversal and recovery. Reversal of muscle relaxation with the combined anticholinesterase and antimuscarinic causes tachycardia, and extubation itself is a stressor. So we have to the problems in recovery phase which can cause ischemia includes tachycardia, pain, hypothermia, shivering, hypoxia, and anemia. These should be treated just prior to the post-operative period. The use of supplemental oxygen in a post-operative period is one of the effective measures in preventing myocardial ischemia. Routine monitoring using ECG, pulse oximetry should be and blood pressure monitoring should be done throughout the post-operative initial 40 hours of the post-operative period. The use of regional anesthetic techniques have advantages like epidural anesthesia reduces the preload and afterload, coagulation responses, and in case of thoracic epidural causes coronary vasodilation. These effects should reduce the perioperative myocardial ischemia. In a patient with ischemic heart disease, local anesthetic techniques such as brachial plexus block should be encouraged in order that hemodynamic responses to general anesthesia can be avoided. Even local anesthesia can subject the patients to stress by the surgical procedure itself. It can also cause some marked hemodynamic effects. Post-operative care for a patient, we have to do continuous ECG monitoring and surveillance for the post-operative myocardial ischemia and infarction. Continuation or institution of a beta blockade guided by clinical parameters should be done. Temperature control should be done, and the provision of supplemental oxygen, adequate pain relief, maintenance of hemodynamic parameters with IV fluids, and deep venous thrombus prophylaxis can be done to avoid the um, myocardial infarction in a patient posted for non-cardiac surgeries. Thank you, sir.
Okay. I have two questions for you. Are you a post-DA student or a primary student?
Primary student, sir.
Primary student. What is the question that has been asked?
Myocardial infarction in a patient posted for a non-cardiac surgery, sir.
Myocardial infarction. That means patient has already suffered an infarction, isn't it?
Yes, sir.
And all the answers that you have prepared, there is another question commonly asked. Evaluation of a patient for non-cardiac surgery is what with a coronary artery disease. Already patient having a coronary artery disease, when they are supposed to undergo a non-cardiac surgery, how would you do a pre-operative evaluation?
Yes,
So
sir.
all the answers that you have prepared is mainly addressing the second question I told you. Pre-operative evaluation of a patient with coronary artery disease coming for non-cardiac surgery. So for that only your answer will completely fit into that. Whereas the question that is asked is again a tricky question, which is have to be thought in a lateral thinking manner, because intraoperative desaturation, intraoperative hypercarbia, intraoperative myocardial infarction, these are all crisis situations where you cannot already patient has come for surgery. He might have had a previous coronary artery disease, or he might have had a normal heart without any coronary artery disease and suddenly developed an intraoperative myocardial ischemia leading to infarction. Okay, so the question is mainly asking you how will you detect intraoperative myocardial infarction, and if you confirm it is a myocardial infarction which has happened on the during the procedure, how are you going to diagnose it? How are you going to manage that? That is what is being asked in the question. So whatever answer that you have elaborately described all this time mainly suits the question which is also very frequently asked in the examination. preoperative evaluation of a patient with coronary artery disease coming for non-cardiac surgery. Okay. So I will just show you a little modification of what you have said by showing